Well, I was fortunate that my career spanned the beginning of interventional cardiology. When I finished my fellowship in 1977, there was no such thing as intervention. But a few months later, Andreas Gruncic performed the first balloon angioplasty, and I was lucky enough to meet him in Boston the following year, and then flew to Zurich to learn the technique from Dr. Gruncic. This was very exciting because it was the first time that it was shown that we could work effectively and safely within the coronary arteries. However, balloon angioplasty had serious limitations, including abrupt closure, which could lead to myocardial infarction, and the need for urgent coronary artery bypass surgery, which occurred in 5 to 10% of cases. In addition to the abrupt closure issue, there was the issue of restenosis following balloon angioplasty, requiring repeat interventions. And I was fortunate enough that I was approached by an executive from Johnson & Johnson who took a little stainless steel slotted tube out of a glass vial and said, "What do you think about this device to overcome the problems with balloon angioplasty?" It sounded reasonable to me. I flew down to San Antonio with him and met Doctors Palmaz and Schatz. We formed a clinical working group to study stents in man. And after a series of observational studies, we were able to publish a randomized comparison of stents versus balloon, and we showed that restenosis was reduced significantly, as was the need for a repeat intervention, but we still had a problem of stent thrombosis, which occurred in about 3.5% of patients. And that problem was somewhat overcome by the work of Dr. Shomig, who showed that antiplatelet agents rather than anticoagulants were far more effective in reducing the dread case of stent thrombosis. So that was a very significant advance. We still had restenosis due to intimal hyperplasia, and we showed in our studies and in the Japanese studies that this was confined mainly to the first 6 months after intervention. And this observation led to the development of drug-eluting stents. So I think going from balloon angioplasty to bare metal stents to drug-eluting stents has been a great advance for patients. We are currently applying coronary intervention to the highest risk patients, including those with left main disease. The mortality from myocardial infarction has been reduced from 30% in the pre-CCU era to about 3% in the coronary reperfusion era. Despite the multiple advances that I've mentioned, mortality from cardiogenic shock remains at a dismal 50%. So we need some better approaches to that devastating problem. And the concept of the use of mechanical support devices prior to coronary intervention is being tested and pioneered by my colleague, Dr. William O'Neill, with the cardiogenic shock initiatives which are taking place around the country. So it would be fabulous if we could reduce mortality from cardiogenic shock. Another area is the idea of detection of vulnerable plaque by newer imaging modalities so that myocardial infarction and sudden cardiac death could be prevented rather than treated in its evolving stages. And I leave that to the future generation of interventional cardiologists. Well, I think advanced imaging technologies are very important. We know also that careful physiologic assessment of stenoses helps in patient selection. We have a better idea of which patient should be done rather than just using the angiogram as a standard. The information in the vessel wall in terms of detection of vulnerable plaques can be approached by such technologies as optical frequency domain imaging, near-infrared spectroscopy, and others. So I think really characterizing which plaques are unstable, which can lead to myocardial infarction and sudden death, will be a very important advance.